Hello and welcome to Reducing Catastrophizing to Prevent and Treat Chronic Pain. We're glad you're here. My name is Angie Hunt, Project Manager with the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant program through the BC government, as well as donations and memberships to CIRPD. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Beth Darnell. Beth Darnell, PhD, is a clinical associate professor in the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University and is faculty in the Stanford System's Neuroscience and Pain Lab. She is a pain psychologist and scientist. She is a past president of the Pain Society of Oregon and co-chair of the Pain Psychology Task Force at the American Academy of Pain Medicine. Her NIH-funded research investigates mechanisms of pain catastrophizing, cognitive behavioral therapy for pain, and the effectiveness of a single-session pain catastrophizing treatment she developed. Additional projects are focused on preventing post-surgical chronic pain and opioid reduction in outpatients with chronic pain. Beth believes that to effectively scale pain treatment efforts must involve improved pain education for patients and healthcare providers alike, and improved access to evidence-based, low-cost behavioral pain treatment. She's author of the Opioid-Free Pain Relief Kit and Less Pain, Fewer Pills, Avoid the Dangers of Prescription Opioids and Gain Control Over Chronic Pain. Beth blogs for Psychology Today and the Huffington Post. Her work and viewpoint have been featured by multiple media outlets, including the San Francisco Chronicle, New York Magazine, More Magazine, Forbes, and Scientific American. And now I'll hand it over to Beth.
Angie, thank you so much, and I'd also like to thank the Institute for inviting me to speak on this topic. So I just want to start off by with my disclosure slide, which is mostly NIH funding that I want to disclose. And then I'll just dive right in. The 2011 Institute of Medicine report on relieving pain in America reveals that globally, about 1 in 3 individuals are living with some type of ongoing pain. And this erodes quality of life. It obviously confers suffering for the individuals and family members. And there's really a tremendous economic burden of chronic pain, both in terms of lost productivity and also medical costs associated with pain care. Recently, there's been a big focus on opioid reduction, and this is an important question, certainly, and I'm sure there's other webinars very specifically on this topic. But the issue at hand, from my perspective and where my work really lies, isn't so much in just reducing opioids. It's in answering the question of how do we treat pain differently and how do we treat pain better so that people are able to live lives that are meaningful to them. To this point, I'd like to invite everyone to read this month's issue of Scientific American Mind, in which they focus on this topic of psychological interventions as a pathway for better pain treatment. And there's a really nice focus on catastrophizing in this article. So psychological disorders and pain have long been bedfellows, and I just wanted to start off with some background on this relationship. And so the evidence suggests that psychological disorders such as depression or anxiety, post-traumatic stress disorder, predispose an individual to develop chronic pain prospectively. And in the other direction, the relationship exists as well. When individuals have chronic pain, they're at much greater likelihood, they're predisposed to acquire various psychological disorders, such as depression, anxiety, and post-traumatic stress disorder. And so there's this co-occurrence that we see. And in fact, it's more than that. We could say that there's really a bidirectional relationship between the two. But in fact, there's the phenomenon of shared mechanisms. So there's this tremendous overlap between psychological disorders and the experience of pain, the acquisition of chronic pain. And there's some underlying mechanisms that involve hormones or immune-to-brain communication. And there's also shared neurobiology between the two. And that's where I'll be focusing a little bit of our time today. So we know that there's tremendous variability in the experience of pain, that two individuals could be exposed to the same type of pain stimulus, and yet they'll report completely different pain intensities. And this is an interesting phenomenon. We all know pain is subjective, but really what underlies much of the individual differences in the experience of pain are psychological factors. And so this is where we sort of get beyond just the question of the relationship between psychopathology and the experience of pain, but really every single person's psychology, their psychological status, and how that influences the amount of pain they feel and whether they go on to have persistence of pain. Pain is a complex experience, tremendously influenced by all different aspects of one's psychology. And in fact, it's psychosocial experience. This really underlies the biopsychosocial model of pain, that the amount of pain we experience is influenced by context and meaning, how we think and feel, our mood, where we're placing our attention, and even the company that we keep. And this makes sense when we put it in the perspective of the definition of pain. And this is a striated definition of pain from the International Association for the Study of Pain. And it's defined as a noxious sensory and emotional experience. So I always like to draw people's attention to the fact that psychology is built into the definition of pain. It's integral to the experience of pain. Far too often, we view pain as being sort of a biomedical phenomenon that's influenced by psychosocial factors, and that we need to address those psychosocial factors to help one cope with the pain that they're feeling. But in fact, psychology is integral to the actual experience of pain, and that's going to be an important point that I will come back to throughout this talk. It's tempting to focus on pain, the site of the body where the pain is felt. But in fact, we know that pain is fundamentally a brain-based phenomenon. It is a product of the nervous system, so it's really the brain and the spinal cord. And our psychology is interacting with pain processing. It's influencing, and it's determining our experience. One example I'd like to use to illustrate this concept is the power of our expectations on pain. And so what's known is that if we expect a treatment to reduce our pain, to confer analgesia, it's much more likely to do so. And if we expect that something is going to make our pain worse, it is much more likely to amplify our pain. And this influence of expectations, sort of the direct influence of our expectations on pain, is really what we talk about when we hear placebo and nocebo. This is the phenomenon of placebo and nocebo, the power of our expectations to actually determine our experience. And this is really nicely illustrated in this study that was conducted in the UK by Irene Tracy and her group. And in this study, they took individuals, and all of the individuals in the study were given a powerful opioid medication, remifentanil, through an IV under 3 different conditions. In one condition, they weren't told anything. They were given the medication without being told they were getting anything. So this was sort of the control. In the second condition, they were told they were getting a very powerful opioid medication that was going to reduce their pain. And in the third condition, they were told that, they were getting something that was probably going to make their pain worse. So they were given, what they were manipulating in this experiment was participants' expectations, but in fact they were given the same opioid medication in all three conditions while they were exposed to a heat stimulus. So they applied heat, I believe it was to the hand, and so they gave them a level of pain intensity, and that was kept consistent across the experiment. And then they simply measured what was the effect of this manipulation of patient expectations, of participant expectations on opioid analgesia. And what they found was that when people were told that they were given an opioid that would reduce their pain, the benefit, the analgesia that people experienced was doubled compared to what they experienced when they weren't told anything. They were just given remifentanil without being told that they were getting it. So the power of placebo, positive expectations, doubled the effectiveness of remifentanil, of analgesia. And for the individuals, when they were told that they were going to experience more pain when they were given the medication, that negative expectation essentially abolished the analgesia conferred by remifentanil, all of this administered through IV. So it's a powerful study that illustrates the power of our expectations. And I'm going to draw our attention back to the power of negative expectations throughout this talk. And in fact, our expectations don't just impact how we respond to exogenous opioids like oral opioids or IV opioids, but in fact, they actually modulate what's happening in our own brains, in our neurochemistry. And so now let's talk about negative expectations. And this is really the realm of pain catastrophizing, a persistent negative mindset for pain. So pain catastrophizing is negative expectation for actual or anticipated pain. It's an over-focus on pain, and it includes feelings of helplessness about pain. So measuring pain catastrophizing. Catastrophizing is a construct that's been around for a while. I like to think of Frank Keefe as really being the godfather of catastrophizing. He really pioneered beautiful work back in the 80s on catastrophizing, and the measure that he and his colleagues developed was the Coping Skills Questionnaire, and there is a catastrophizing subscale in this measure, and it's 6 items that really measure this negative mindset, the extent to which a person is persistently holding negative expectation for pain. And then in the mid-90s, the pain catastrophizing scale was put forward by Mick Sullivan and colleagues. And this is a 13-item measure with 3 subscales. And this is more widely used. So if you're steeped in the literature on catastrophizing, you're more likely to see people using and reporting on the pain catastrophizing scale. And these items on this slide are directly taken from the pain catastrophizing scale, and they are broken out into the subscales for magnification, rumination, and feelings of helplessness about pain. So you can actually see the individual items here. And these items, the directions of the pain catastrophizing scale ask individuals to consider how they tend to think and feel when they experience pain, and to rate the frequency at which they experience these various, they would endorse these various statements to be true. And so what a person is rating is, again, the frequency. So 0 being never, not at all, and 4 being all the time. So it's a 5-point scale that they use. And we sum those 13 items to get a total score. So the scale ranges from 0 to 52. And traditionally, a lot of clinicians and even some researchers will point to something of a cut score in the range of 27 or 30 because the study that's widely cited is one that predicts this cut range as being predictive for disability. But in fact, what we're observing is that catastrophizing at much lower levels does exert negative influence and does have negative prognostic value for treatment outcomes. And so I will be presenting some of those data as we go forward. So when I work with my patients, I like to describe pain to them as being their harm alarm. Pain is designed to get our attention, and it does that really well. It gets our attention, it alerts us that there may be harm or danger afoot, and that we should take action to escape potential harm, to ensure survival. So pain is incredibly useful in that acute sense. If there's an acute circumstance in which we're experiencing pain and we do have the opportunity to escape whatever that may be, if we placed our hand on a hot stove, for instance, we can readily remove our hand and protect ourselves from further harm. But once pain becomes chronic, we can't readily escape what's coming from inside of us. In fact, in most cases, it's impossible, and this creates a large amount of distress for most people who have chronic pain. And so while we're born with the motivation to escape pain, we're not born understanding how to modulate pain or the distress that it causes us. And this is really learned skills and information, and this is really the realm of pain psychology and the work that we're doing. So when left untreated, sort of left to its own devices, catastrophizing can happen naturally to some extent. It happens to some degree or another with most people who experience pain on an ongoing basis. However, the level at which a person catastrophizes is really what determines whether or not a person is at risk for negative outcomes. And so I wanted to present some of the data for some of the negative outcomes, negative associations for pain catastrophizing. It's really associated with an array of negative outcomes, including affective distress, muscle and joint tenderness, pain-related disability, as I mentioned. It mediates the efficacy of other pain treatments, so it has the capacity to undermine other treatments that may be tried. I'll have more to say about that as we go forward. Additional negative outcomes, a poor response to surgery. People who catastrophize have longer hospital stays when they are in the hospital, and there's associations with greater use and misuse of opioids. So I think the data are consistently clear. There's been about 25 years or more than a quarter century of data that has described the negative influence of catastrophizing and the really pointing to the importance of catastrophizing as a therapeutic target. So how do we treat pain catastrophizing? The best evidence is for cognitive behavioral therapy. And this work has been pioneered by legends such as Frank Keith, Beverly Thorne, John Burns, Dan Cherkin, also Mark Jensen and Judy Turner. There really are an array of studies across multiple research groups, independent research groups, multiple institutions that have focused on cognitive behavioral therapy specifically to and measured its impact on catastrophizing and have shown it to be evidence-based treatment. CBT, as we call it, is maybe delivered individually. Typically in the research context, it's delivered in group format. So you may have 10, 15 individuals who attend typically 8 sessions of CBT, and in these sessions, participants learn various information related to self-regulation of cognition, of emotion, and even learning which choices support good pain control. So CBT isn't really entirely focused on catastrophizing, but there are elements of it that do focus specifically on catastrophizing, and it does have really nice effects. Newer research has shown that mindfulness-based stress reduction is effective for reducing catastrophizing, even though it doesn't specifically target pain catastrophizing in the course of treatment. An individual learns how to essentially disengage from stressful information, how to simply be with thoughts without trying to control them, and that appears to confer a level of relief that we see not only for the experience of pain, but also for reducing this pain-related distress. Some research has shown that yoga that involves aspects of some targeted strategies to reduce distress is effective for reducing pain catastrophizing. Acceptance and commitment therapy, similarly, typically 8 sessions. This is a variation of cognitive behavioral therapy. And newer treatments that are focusing on a combination of physical therapy and cognitive behavioral strategies. I haven't seen published results using these techniques as yet, but there are nice protocols available describing some NIH-funded work that is ongoing, with the hopes that they're able to show that catastrophizing can be effectively treated during physical therapy sessions and delivered by a physical therapist, and that would be really nice progress that could improve access to treatment for pain catastrophizing. I wanted to highlight this particular study. This is by Dan Cherkin and his colleagues at Group Health Initiative, and they did a head-to-head comparison of CBT and MBSR for chronic pain. And this was interesting because there's not a lot of studies that really compare these treatments, because you might say, well, okay, great, Beth, there's all these treatments that kind of, you showed that data that says they work, but which is best? And there really aren't that many studies that are comparative, and so there's a lot of variability in studies, different pain conditions, different participants, et cetera. But this one was really cleanly done, and what they showed in this sample of individuals with chronic low back pain was essentially equivalence between MBSR and CBT for chronic low back pain. And so that is nice because MBSR can be an additional treatment pathway where you don't necessarily have to find a skilled psychologist, but for certain individuals it can gain relief in this more widely available treatment pathway, although recognizing that insurance does not typically cover MBSR. But nevertheless, to date, nothing has been shown to be superior to CBT for reducing catastrophizing. It's considered the gold standard evidence-based treatment for catastrophizing. So I just wanted to spend very quickly a moment talking about mechanisms of catastrophizing, because it will set the stage for some of our future slides. And so really there's multiple mechanisms behind catastrophizing and why it exerts such a negative influence on pain and on pain outcomes. But what I wanted to just focus on was some of these neurobiological mechanisms. And what the literature shows is that pain catastrophizing really shapes neural functioning, neural patterns. And we see this when a person is catastrophizing in vivo. Like, you can put people into the scanner, the fMRI scanner, and if we give a pain stimulus and a person is catastrophizing, we can see differential patterns in their brain based on the fact that they are catastrophizing. But what's more interesting than that is that when people are true catastrophizers, meaning they engage in this repetitive pattern of negative mindset for pain, we see that that appears to shape the brain in such a way that their brains are different than non-catastrophizers when their brain is in a resting state. And that's important because when we are in a resting state, that's sort of our everyday state, our relaxed state. And people who catastrophize have a different state that puts them, it predisposes them to have future pain. So literally the nervous system becomes primed for more pain. So it's almost like with catastrophizing, it establishes patterns that are then that much easier to access in the future. And this, our group described some of these associations in this paper that was published last year, where we were comparing individuals who were healthy to individuals with chronic pain, with chronic back pain. And what was shown in this study was that very specifically in people who catastrophize, there is an overcoupling in the central executive network and the amygdala, such that their brains look more like individuals who have an anxiety disorder. But in fact, these people with chronic pain do not have an anxiety disorder, but their brain has been shaped in that direction. Other research, this in migraineurs, showing that with catastrophizing, there's altered brain structure and function. We see that this altered brain structure and altered function is a consequence of the duration that a person has had migraine and also the severity of migraine, but that catastrophizing is a very important overlay that predicts the extent of these structural and functional changes in their brains. So I like to tell the people that I work with, and when I teach my classes, I say, imagine that this fire is your pain. And when you catastrophize, it's like picking up a can of gasoline and pouring it on that fire. And it literally lights up the regions of the brain associated with pain processing. So patients can literally grow pain in their nervous system. Now, I can teach people how to stop catastrophizing. It will not make them pain-free, but this is possible. We can help get people back to a level of control where they have much less distress and a much better quality of life, and that's really the goal. So recently, our group has been interested in understanding associations between pain catastrophizing, pain intensity, and likelihood to have an opioid prescription. And this is sort of a hot topic now with a lot of the focus, national and international focus on opioid prescribing. And what we found was that, unsurprisingly, pain catastrophizing and pain intensity were both independently predictive of likelihood to have an opioid prescription. But what was interesting was that we found an interaction between pain intensity and pain catastrophizing. And we found that this interaction differed between men and women, such that for men, they were more likely to have an opioid prescription if they had greater pain intensity. Whereas for women, having an opioid prescription was predicted more so by their level of catastrophizing. And these dots here that you see are individual patients. This was conducted in a study that included 1,800 patients from the Stanford Pain Management Center. So it's a very large data set that we analyzed to arrive at these results. And here what we see is that red, the darker shade of the red, is a greater likelihood to have opioid prescription. And what we found was that these sex differences emerged quite early on. So I had mentioned many slides ago that with the pain catastrophizing scale, it exists on a range, a continuum from 0 to 52, and that often people will determined that somewhere around the range of 27 or 30, somewhere in there and higher, is indicative of a need for intervention, a need for treatment. But in fact, what we were showing in this study is that these sex differences in catastrophizing and its association with opioid prescription, that they emerge much earlier in the process. In fact, you can see that there's sort of an inflection point here right around the range of 11 or 12, somewhere in that range where you really see women separating from men in terms of their likelihood for prescription and its association with catastrophizing. And we're not alone in putting forward data that suggests that much lower levels of catastrophizing, what we would historically describe as sub-threshold or subclinical levels of catastrophizing, are actually important, that we should be treating earlier on in the process and at much lower levels. So earlier I showed some slides about how catastrophizing is associated with changes in brain structure and brain function. And I also put forward a slide talking about how catastrophizing is effectively treated with multiple therapies, but really the best evidence is for cognitive behavioral therapy. And a question I frequently get asked is, okay, so if I do CBT, is that going to make my brain healthy again? And of course, that's a natural question to ask. And the answer that I'm really pleased to share is yes. This was a really elegant study done by David Simonowitz and colleagues. And what they did in this study was they took participants who were about to undergo CBT. These are patients with chronic pain, and they scanned their brains. Then they had them go through 11 weeks of cognitive behavioral therapy, group cognitive behavioral therapy, and then they scanned their brains again post-treatment. And what they showed in these sort of comparisons between pre-treatment and post-treatment scans was the following. They showed that at pre-treatment, they showed that people had deficits in sort of atrophy in the regions of the brain associated with pain control. And after going through this 11 weeks of CBT, their post-treatment brain scans showed that there were clear, significant volumetric increases in these regions of the brain associated with pain control. And so that in and of itself is just super cool, this idea that you can go through, 11 weeks of group CBT and literally grow, strengthen your brain. There it is, the evidence. But here's what's even more interesting, is that these results, these brain changes, were entirely mediated by reductions in catastrophizing. So yet again, evidence underscoring the importance of treating catastrophizing and its power to mediate all other types of treatments. So clearly, wouldn't it be important to give all of our patients access to CBT or other treatments that are useful for reducing catastrophizing? This actually happens to be a problem in the country because there aren't as many skilled providers as we need. The National Pain Strategy, the IOM report describing these great needs to treat the 100 million Americans, that's just in the United States, but 1 in 3 individuals living with some type of ongoing pain, how are we going to treat them all? This study here evidencing a great lack of resources in terms of skilled therapists and clinicians who can provide cognitive behavioral therapy or other treatments to address the needs of millions of individuals who have pain. So training more therapists is critical, and some changes are on the horizon in that regard. But we also need to think beyond. We need to think about how to develop novel treatments that can dismantle many of the barriers that currently exist. Those barriers being the cost for CBT, insurance reimbursement, that many patients can't get to 8, 10, or 11 treatment sessions. So how are we going to better meet the needs of individuals with chronic pain? So this was a goal of mine back in 2013. What I wanted to do was extract out some of the key information from those 8 sessions of CBT and put it into a compressed class, a one-time class. And that was, this article here that you see on the screen describes the results of this pilot study for a single session targeted class. It focally addresses pain catastrophizing. And our goals were to see, first of all, to conduct a feasibility study, also to collect data for participant satisfaction, and to see whether it would have an impact on catastrophizing scores if a one-time class could impact that. And so in this class, participants learned some of the key information. I mean, it really is compressed cognitive behavioral therapy combined with pain education. And people learn that pain isn't a passive process, and they learn where their areas of control do lie. And this is a critical pathway for them, because nobody wants more pain. We know that catastrophizing causes greater distress. It actually amplifies pain intensity, and nobody wants that on the surface. But if they don't have the right information, if they don't have the right skills, then they're unwittingly amplifying their own pain and contributing to their own distress. So we found some really nice results for this single session class in terms of reducing catastrophizing scores at post-treatment weeks 2 and 4. And we found these changes to be moderately and substantially important. So we always want to look at the clinical importance of reductions in catastrophizing, or whatever the outcome is. Ultimately, we found large effect sizes for weeks 2 and week 4. And we used these data to acquire an R01 award from NCCAH. And in this grant award, we're conducting a 3-arm randomized controlled trial comparing the single session class to 8-week CBT to health education control group. And what we are describing in this trial, not only are we sort of doing comparative effectiveness, but we're also aiming to describe the mechanisms of how catastrophizing changes. We're also piloting this work in cancer outpatients currently. So it's important to phenotype our patients. Who is catastrophizing and who isn't? We want to identify those that are, deliver targeted therapies, and also track their outcomes over time. And so we have this beautiful tool at Stanford called Choir. It's Collaborative Health Outcomes Information Registry. It is a learning health system that allows us to phenotype, deliver therapies, and track outcomes over time. This is a patient report for Choir. This is, you can see the body map. This person has pain in her feet. You can see her longitudinal scores for pain intensity, for various PROMIS outcomes measures that we've captured over time. You see the nice graphical display. And we also capture data for the pain catastrophizing scale. And so we get this really nice longitudinal data on catastrophizing where we can see what is changing. And this just happens to be a long-term patient of mine who I did my initial intake with her in June of 16. And her score was high, and she immediately took the class that I offered, and you can see how she had a precipitous drop that she maintained literally to this day. I didn't see her too long ago. And even when depression and anxiety have been increasing, she's still maintaining these nice gains. So I am showing these outputs for choir because they give us a nice platform to understand what treatments we need to deliver and how they're working. This has also been applied in the pediatric pain clinic here at Stanford. And in this publication, they are describing how this can be used not only to address catastrophizing in the child's patient, but also in the caregiver. And so it's critical in pediatric pain to also treat the parents, because parental catastrophizing turns out to have a tremendous influence on child outcomes for pain, and in some cases even more predictive than the child's own catastrophizing, but parental catastrophizing being an important therapeutic target, and that is certainly a topic for a separate webinar. But in terms of treatment to prevent chronic pain, one of the things that we can do is really target at-risk healthy individuals. So for instance, the children of mothers and fathers who have chronic pain, and be able to deliver interventions early in people who are seemingly healthy but have risk factors at play. There's opportunities to treat non-surgical acute pain as a pathway to prevent chronic pain, even in healthy individuals, and certainly pre and post surgery. So surgery, you know, we describe it as sort of being a controlled injury, and a person's psychological disposition has a tremendous influence on their outcomes of that injury, unsurprisingly. And this is important because there's 230 million surgical procedures that occur every year, and up to 10% of individuals go on to have chronic post-surgical pain. For some surgeries, like total knee arthroplasty, the chronic pain after surgery, the rates for chronic pain are up as high as 35%. So surgery is represents a nice opportunity to help people gain better outcomes if we're able to phenotype patients ahead of surgery and deliver those targeted treatments. So just very quickly, some of this data for pre-surgical pain catastrophizing in a multitude of studies, this being a meta-analysis that included over 5,000 surgical patients. Catastrophizing was the strongest predictor for post-surgical chronic pain. We see it relates to length of hospital stay, delayed early recovery from surgery, post-surgical function. So some of those it's sort of a familiar theme that we saw in outpatients, but now we're seeing it in all of those metrics of health and recovery for surgical patients. So I wanted to understand what was available for pain catastrophizing treatment in the perioperative setting. And at the time that I did this review in late 2015, early 2016, there really wasn't much available at that time, just a few small pilot studies and really a sparse field at that. What our group has done, this is, I'll explain our status of this study, but we essentially took that 2-hour class that we published and received that NIH award for, took that class and adapted it to surgical patients. And we put it on video. So this is a internet-based perioperative psychobehavioral treatment, and it's targeting pain and improved recovery by addressing catastrophizing. And so this is one-stop shopping for catastrophizing treatment. It's important to know that people who enter My Surgical Success don't interface with a person at all. They have to get the website from a study coordinator or a nurse, but they go to the website and they're perfectly independent at that point. They engage in the program, they print their plan, they watch the video, they download an audio file, and after that we just track their outcomes, how they do, how they respond to the treatment and how they do. So we have just finished a randomized controlled trial in 90 women with breast cancer who are undergoing surgery. And so as you can see, pre-surgery, we randomized to group treatment. We collect their baseline measures. They are delivered their treatment, and after the surgery, we track them daily for the first month for pain and opioid ratings, and then we have a graded measurement system to continue to track their outcomes up to 3 months. But very importantly, what we are trying to understand is whether this type of an internet-based treatment can improve time to pain cessation and time to opioid cessation after surgery. So really looking at this as an opioid-sparing treatment or a way to improve recovery and reduce pain. We are excited to have this article in press. We developed and validated a daily pain catastrophizing scale. This is an important tool for researchers particularly researchers who may be doing diary studies, mechanism studies, or pre and post-surgery studies where you do want to capture those daily ratings to understand when pain stops, when opioids stop, and also its relationship to catastrophizing. With Choir, I had mentioned that we use that in the outpatient setting, that learning health system that phenotypes patients. We have this now in the perioperative clinic at Stanford hospitals. And so the next step for us is to include a couple of questions on catastrophizing. So the idea is that we can phenotype people who are catastrophizing, who are at risk for negative post-surgical outcomes, phenotype them on the front end, and have an automated link be sent to them before surgery. Oh, hey, watch my surgical success. We have a treatment we would like you to engage in, or we'd like you to view this educational material. Here was your score, and here's what that indicates. And so that we could have this true learning health system deploy those targeted treatments to patients so that they can engage in them in the comfort of their own home, even when they're not able to travel or they have other limitations. Recognizing that this type of a platform isn't going to be for everybody. There are certainly people who will absolutely need to work one-on-one with a skilled psychologist who really need that ongoing individual work. But what we're trying to do is address the needs of millions of people who may not have access to that level of care. And can we develop materials that could also be used in the clinic with, let's say, psychologists who maybe don't have some of that advanced skill set regarding pain, but they can work with their patients to watch videos or to engage in an internet-based treatment platform. So there's been much focus from the IOM, from the CDC, and even the National Pain Strategy in terms of really recognizing the value of psychobehavioral interventions, self-management, and integrating this more into pain care. If you ask me who needs psychological treatment for pain, my response would be everybody, because I think as a field, as clinicians and as researchers, I believe that the data is telling us to begin looking beyond some of the cut scores of yesterday and to begin focusing more on reducing risks and also focusing more on this idea of simply optimizing patients for best outcome possible by helping them harness the power of a positive mindset. So for the clinicians who might be on the webinar, I wanted to just close out by giving some really practical tips about what you can do in working with your patients. Educate your patients that mindset matters. How one responds to their pain is a critical determinant, and it is vitally important that they understand what they can do to help themselves. Screen your patients. Understand whether they are catastrophizing or not. Ideally, we focus on treating individuals before they have interventions. I sort of have this fantasy that we could start deploying some of these types of treatments before prescriptions are started, certainly before surgeries. We have a long ways to go, but there are some early steps in that direction. This idea of focusing on behavioral medicine as first line or front line and not the last resort. Recognize that intervention begins with you, so how you speak to the patient, how you engage with the patient. And so providing that rationale to empower them to participate positively in their outcomes and focusing on aligning with them and what really is an act of a team effort, so you're partnering together to help them. In terms of referring your patients, you may refer to skilled pain psychologists, health psychologists. There are general skilled psychologists, though admittedly they're harder to find. This was quantified in our National Needs Assessment. General pain education classes may be available in your institution or your community, mindfulness-based stress reduction, and also some gentle yoga. So there is evidence for these treatments. And ideally, in treatment, patients learn to identify pain catastrophizing when it's happening, so they need to know what it is and how to spot it, and then to apply skills to adaptively self-regulate. And lastly, timing matters. So this is really nice work that has been conducted by John Burns, showing that it's the early reductions in pain catastrophizing that lead to better treatment response. And so that really goes back to that overall theme that what's happening with our mindset can either support all of the treatments that physicians in our medical system will try, or our mindset may undermine them, unwittingly so, but that's what's happening, regardless of whether we want it to or not. So simply recognizing the impact of mindset, identifying it early on, applying treatments where appropriate as early as possible. So in closing, I'd just like to say that this is where I see the future heading, where we are heading in this field. I think that we really need integrated systems for phenotyping so that, again, such as with Choir, where we can see what's happening with our patients and that we're continually reminded of that. We're continually tracking on that. So we can't meet our patients' needs if we don't know what they are, is sort of the subtext. So integrated systems for phenotyping and then delivering those targeted treatments, a continued focus on dismantling barriers to care. That means more of these briefer targeted sessions or online treatments. I think there'll be more and more of that in the future. Integration of technology, so again, some of the online work, maybe apps, etc. And thinking beyond existing treatment paradigms, the field has really focused, even with cognitive behavioral therapy, on 8 sessions and studying 8 sessions. But it's odd to me that when we talk about a prescription, a person gets refills and, they take that medication for, often years at a time, if not decades. They're getting refills, but with psychological treatments, there's this curiosity where we refer people to CBT maybe once and they stop and that's it. And so thinking beyond that treatment paradigm that perhaps we need booster sessions or additional levels of care, that I have a fantasy that we could begin thinking of it more as levels of lifestyle intervention or intervention for pain. And I don't know exactly what that's going to look like, but I do think that the field will begin exploring some of these traditional notions of what it is and when we need it. And again, focusing a little bit more towards optimization at every stage. So with that, I just want to thank my colleagues and collaborators. I do want to let you know that I have some print resources on this final slide, and I'll just come back to this, this one here, and I think Angie is going to aptly moderate questions if there are any.
And thanks, Beth. We have a few questions, so if we do go over our time limit, rest assured we'll answer your question in email. First question, do you believe that the brain can be trained to allow for the self-management of persistent pain?
That the brain can be trained to allow for persistence of pain?
For the self-management of persistent pain?
Oh, absolutely. The data support that. So if I'm understanding the question correctly, it's almost like the question is, can you learn to train your brain away from pain? And the data absolutely support that unequivocally. And they support it not only from treatment outcome studies where the evidence is in patient report, but that the MRI data also provide an additional layer of support where you actually see changes in the structure and function of the brain. So yes, and that's exciting.
Okay. Could there be negative and positive expectations for pain affected by the indigenous opioid production, i.e. individuals with negative feeling might have increase in a receptor sites unfilled where they still need more compared to the positive feelings?
Yeah, that's a really interesting question, and there is a vast literature looking at the interface between expectations and reward, and again, you know, the intersection between opioids, endogenous opioids, dopamine, et cetera, you know, whatever is going to confer reward. We know that those are powerfully influenced by expectations. So the question of the receptors very specifically, that's a little outside the scope of my area of knowledge, but I would encourage you to dive into that literature because I think you're on the right track.
All right, next question. Do you have specific CBT techniques to recommend?
Well, the cognitive behavioral therapy for pain is pretty well protocolized. And so that involves cognitive restructuring. So first of all, identification of some of these negative or maladaptive thoughts and beliefs about pain. And once those are identified, participants or patients engage in strategies to shift them. So it's called thought restructuring, where it's almost like practicing a different viewpoint, different self-talk, different language over time, and then observing how that might change how you feel and the choices that you make. So this is, you know, this is one of the areas that's sort of bedrock to cognitive behavioral therapy, is identifying maladaptive thoughts and changing them. A second skill that is critical and importantly really underlies every single one of those treatments that I listed, that where there is any data to show it's effective for reducing catastrophizing, it's the relaxation response. And the relaxation response is critical. It's critical because it helps people stop catastrophizing. They learn to essentially regulate physiological stress responses. So they learn to reduce heart rate, respiratory rate, they release tension in their muscles, they learn to calm their mind by affecting the relaxation response. And when this is used regularly over time, it teaches people that they do have a level of control, not only over their distress, but over how their body is functioning, responding. And this is a critically important skill set for people to learn and to practice over time. So those are just two. I would direct you to, there are many books on CBT for chronic pain. Bev Thorne has written a lovely book on the topic. I also, in my print resources, I listed the Turk and Winters book, The Pain Survival Guide. Now that's a book for patients, it's not for clinicians, but it's an excellent book that really goes through all of the key skills for CBT for chronic pain.
Oh, and if it's not in your presentation already, we can definitely include that in the webinar materials following when we post the recording and the slides on the website too.
Okay.
Next question. Are the resources, i.e. Choir, My Successful Surgery, available in Canada for clinicians? Do you know?
So Choir is, in fact, it is a free and open source learning health system. So you can like Google Choir and Stanford and learn more about it. There have been some talks with various areas of Canadian government with integrating this learning health system into healthcare systems in Canada. But truthfully, I don't know the status of that at this time. But what's important for you to hear is that it's free. It's essentially open source. You need to sign a licensing agreement where you agree not to redistribute the code or monetize it. But beyond that, you can integrate it into your healthcare system and begin using it to phenotype your patients. The My Surgical Success program, we are analyzing the data for that study as we speak, and so we need to publish on it before we make it freely available, but that certainly is the goal. I am eager to make that available online for free as soon as possible. Unfortunately, it's not at this point in time, but stay tuned.
Okay. Well, a few more questions as we're just out of time. Why does a decreased area of brain pathways that control pain lead to increased pain? Referring to the Seminitz article that was cited?
David, so the Seminowitz article, that study, what that showed was that when people reduce catastrophizing, that is related to increases in the region, volumetric increases in the regions of the brain associated with pain control. So essentially, sort of the simplistic way to think about it is that when you stop catastrophizing and direct your brain in directions that are focusing on reducing your own pain, that is evidenced neurologically, structurally in your brain scans. So just like someone who is training in the gym and exercising and you gain strength, and that's evidenced by gains in muscle, they are showing those same types of gains in the volume of the brain in those regions, which is correlates, so you can think of that as strength. It correlates with the patient report of reduced catastrophizing and better control over their pain.
Okay, great. We're just at time here, and we do have a lot more questions. So if I don't mind, Beth, we'll send those to you to be emailed personally. Was there anything that you'd like to add following your presentation?
Oh, I would just like to invite everyone to visit my website. I post articles there. There are podcasts. There's some videos, etc. And so if you're interested in resources and learning more, hearing more on this topic, that can be a nice resource for you.
Okay, great. We can also include that website link in the GoToWebinar final documents. Thank you so much for your presentation.
Yeah. Thank you. Thank you so much.
You're just going to go